Hello and welcome everyone to today's webinar from eConsult. My name's Tim Ringrose and I'm here with you as the chair for today, for this morning. I'm a clinician with a big interest in digital health, and I'm current president of the digital health section at the Royal Society of Medicine. And I'm really pleased to be involved in today's webinar. We're going to be talking about outpatients and digital transformation. But before we get on to that, I'd just like to mention some housekeeping things. We really want to make this webinar as interactive as possible, so please do put in your questions. Just click on the question tab and type away. You can also upvote, so if someone else has asked a question and you think it's a good one, do upvote it. And we'd also like to know how you feel, so you can use the react button to let us know what you're thinking. If by some chance you can't hear, then thank you for that. If by some chance you can't hear, please just click on the screen and that should activate your sound. But if you've got any other problems, and you can do, then please type in the questions and we'll do our best to try to sort things out. Now, this webinar is recorded. So after the webinar, you'll receive a link with the recording, and we'll also be sending out the dates for the next webinar, because this is the first of a series of 3 webinars. So we're going to be hearing from some great speakers today. First of all, we have Professor Tony Young. Now, I don't think Tony needs an introduction to anybody, but just in case you don't know who Tony is, if you're the one person in Britain who doesn't, Tony is the National Clinical Lead for Innovation at NHS England, and he's also Associate Medical Director at Mid and South Essex NHS Foundation Trust. And with him we have Erica White, who's Programme Director for Innovation and Entrepreneurship at Mid and South Essex, and Chris Whittle from eConsult. And today we're going to be hearing about the launch of a really exciting project for outpatients at Mid and South Essex. But before we hear from our speakers, I'd like to hear from you. So we're going to launch a poll, and I'd like to hear from you about what do you think is the biggest challenge that you are focusing on at the moment with regards to outpatients. So if we can launch the poll. Are you focused on enhancing patient-initiated follow-up uptake, increasing remote consultations, increasing advice and guidance, reducing referral to treatment, reducing DNA rates, or is there something else? If you do click on the something else option, please do let us know what you're thinking about by typing it into the question tab. So we'll give a few more minutes. We've got quite a good number of votes so far. Okay, so can we publish those results? So we're getting increasing remote consultation uptake as the leading challenge, closely followed by enhancing patient-initiated follow-up uptake. And increasing remote consultation uptake is leading ahead at 35%. Great, really good to hear. So we'll come back to that and we'll discuss some of these issues in our discussion. But now I'd like to hand over to Tony. So Tony, over to you.
Thanks so much, Tim, and good morning. I'm really pleased to be here. Chris did the very dangerous thing when he was briefing me about this. And he said, you've got 10 minutes, but you know, if you're really excited and you can have a bit longer, so just a no. So you know, I'm actually going to, anyone knows me will know I'll just talk. So what I'm going to do, I'm going to set the timer on my phone. So, because there's nothing worse than someone who just carried, they are 10 minutes. So I can't go beyond that. So when you hear a bleep go, right. So look, I am essentially a plumber from Essex, despite Tim's very, comprehensive summary of who I am and what I do. I'm a urologist in Southend, and have been there for 15 years as a consultant. For the last few years, I've been associate medical director. They're responsible for innovation and helping lead and transform the way we do services. I'm also an academic at Anglo Ruskin University, chair and director of innovation and entrepreneurship. And that's because I did 4 startups myself alongside my surgical training, raised 5 million, exited them all. But I have the scars on my back from trying to be an entrepreneur in the National Health Service. And then for the last 8 years, I've been the National Clinical Lead for Innovation at NHS England, originally appointed by Sir Bruce Keogh, our former National Medical Director, with a remit at NHS England of helping us address the inequality agenda, getting the latest, greatest things taken up. Growing the life science economy in the UK. I've become the senior clinical advisor across NHS, arm's length bodies, government departments, public sector, private sector, and foreign governments that come and see us around healthcare and life science innovation from a clinical perspective, and therefore do a whole load of projects and programs on that. And then Bruce said, but really just make us a go-to place for healthcare innovation, Tony. And but you've got no money and no power. Go and see what you can do. And anyone from the NHS will go, oh, typical story, no money, no power. And we're expected to change the world. But it was actually in my job description. So I've been there 8 years, been under various leaders that I've reported into, now sit under Tim. I was going to say Tim Ringrose, but I don't sit under Tim Ringrose. Isn't that terrible? Who's the Tim I sit under? It's just gone. We all know who it is. Someone will help me out.
Tim Ferriss.
Tim Ferriss. Yeah, no, I was thinking, because of course Tim Ferriss is also the body coach, and I had a real problem with that when I first started, because our clinical entrepreneurs would get me trying to read some of this, how to get a 4-hour fit body or something. But he's not that Tim Ferriss. He is the Tim Ferriss who used to be the managing director at Mass General Hospital, who's come over, of course. And it's recorded as well. I just had brain freeze. And when you get brain freeze, just embrace it and go for it and say, look, that's why I've done that. And now I report in the Transformation Directorate, and that's one of the largest directorates, I think the largest one now in NHS England, for helping us really transform our workforce and the way we do things. And I do a whole load of things there, all sorting out a national IP policy. I'm the clinical lead on that for tech transfer, a whole new education program on innovation, transformation, digital readiness for our workforce, and founded the Clinical Entrepreneur Program 6 years ago. So until 6 years ago, we didn't support people who wanted to be entrepreneurs in the NHS. And quite frankly, we did the reverse of that. When a couple of junior doctors who were about to quit healthcare, and because they'd raised the stuff up, in fact, they had quit, came to see Bruce Keogh and myself. And Bruce said, we're going to lose a lot of really bright talent here, Tony, sort it out. Long story short, founded the Clinical Entrepreneur Program, now the world's largest workforce development program in healthcare. 900 clinical entrepreneurs on the program, roughly, at the moment. Headline figures are, our year 6 data will be out soon. It's around about 400 startups have been created in the last 6 years or supported. And about £500 million they've raised in their time on the program, impacted over 100 million patients and professionals we can count, and built about 5% of the UK life science industry from scratch in the last 5 years. Unprecedented. Never have startups had such an impact on healthcare. And you're saying, why is he telling this about his role? He's got 10 minutes. And the reason for that is Chris Whistle, who you're about to hear from, was one of our clinical entrepreneurs. And he got a great startup. We'll tell you a little bit about that maybe in a minute. Who knows? QDoctor. And it was a video consultation platform, really great. I think it was, if not the leading one of the leading ones in the country, and certainly in how it was rated and assessed by CQC. But like all of them, business models were difficult. And I also knew eConsult, and I knew Murray Ellender, CEO there, and Claire Gerarda, and Arvind Madan, who'd set that up. And I knew what a great organization that was, and I really wanted to support them more. And I said, look, guys, you haven't got a video consultation system on eConsult yet. I know Chris, he's one of our entrepreneurs at NHS England. Why don't the two of you get together? And guess what? Maybe I am entrepreneurial matchmaker in chief for the NHS. I'm not quite sure. Anyway, the match worked. And now eConsult kind of acquired QDoctor, and now that's embedded in their video consultation system. So at that time, we were talking in Mid and South Essex with Erica White, my director here, and Charlotte Williams, who's our group director of strategy and transformation in Mid and South Essex. I'm really going, come on, we've got to solve the future of outpatients. How are we going to do it? It was about 3 years ago, and the NHS England outpatient transformation exemplar call had just closed. So I knew Linda Charles Azuzu, who was then director, and I said, oh, look, we've been thinking on this piece of work, and, you know, I've been really challenged about it. And I've been doing some thinking on the digitalization of healthcare in the innovation research and life science team at NHS England. And, you know, we've got lots of slices of the salami that will help us solve the problem, but no one's got a whole salami. And we need to bring it all together. I think you're going to see the whole salami today is what I'm trying. Then eConsult have never been called that, but they are, in my view. So what can we do about that? And people are saying to me, come on, Tony, you're the national lead for innovation. Surely we can bring together things and make this all happen. It's a bold vision. Could we truly, really digitize the whole of outpatients, link it into primary care, into then inpatient care, just have a joined up pathway? And I'm going, okay, so I went around the world. I looked at everything there was across the planet, from the United States, Europe, Asia, Australia, that I could find. And you've got to, in my role at NHS England, I met 1,000 companies a year doing things. And eventually I ended back in South London near Skipton House at eConsult, not a stone's throw away, having scoured the planet. And we shortlisted a few companies to come and work with us in Mid and South Essex. I had a vision of building this nationally. I was supported at the time by the then Secretary of State, Matt Hancock, I should say, to really do the piece of work on this. And he was very supportive. But, you know, politicians progress through, don't they? And I had some real support at NHS England, but it was clear that we had to try and do something locally to make it work, to get it over the line. We'd had a number of conversations about doing this really big and nationally, all in one go. And for a variety of reasons, that wasn't going to work. So I got eConsult round the table, and now they're partnered with Patients Know Best for the patient care record that we need, and with Erica, who you're going to hear from in a minute, and Charlotte Williams, and the support of my Chief Executive, Claire Paniker. Claire Paniker, you may know, has just left and become the East of England Regional Director for NHS England. So kind of between the four of us, but Claire gave us her blessing and support and just say, okay, Tony, we'll get this through. It did take us 2 years. And, you know, I think Erica and I both got the scars on our backs. Erica, she never gave up, not once. She believed it. And we said, we can do this. We don't have to do it small. We can go big. And eConsult took a massive risk on us. They knew me, and I think that helped. And they got to meet Erica, and they got to meet Charlotte. And they knew we had the support of our chief exec and our finance director, Dawn Scrayfield, too. So I put that all together over the weekend and said to Linda Charles Azuzu at NHS England, I bet you won't even have looked at your submissions yet. She said, I won't. Will you take a late one? And they did. And so in that round of the NHS England outpatient transformation exemplars, we came top by a country mile and actually got awarded not a lot of money, but double anyone else for the most technologically advanced proposal they had seen. Essentially, what we said we would do is we will take the signal coming from primary care. Now, that could be a direct referral, or it could be just advice and guidance. We'll take that into our cloud system where a clinician, it could be a consultant, it could be a nurse, it could be another appropriate member of staff, where that can be triaged and they can dispatch a clinical questionnaire for more details, order blood tests or imaging, whatever they require. Those results can come back to the cloud and the clinician can review them there and say, actually, I don't need to see you. This was a simple renal cyst. It needs no further follow-up. And you could send them an email and discharge them, or it could be a text message, or you could offer them a telephone call or a video consultation. Or you could offer to bring them in face-to-face if the patient needed it or needed reassurance, or you needed to see them to examine them, for example. Oh dear, that's my 10 minutes. But Chris did tell me I can go a bit longer, so I'm going to. So what we did was we and brought this into cloud. Now we know from eConsult's primary care data, they're doing over 1 million outpatient consultations and triages through that system every month in primary care. We know about 70% of people, when they go to that system, don't have to be seen face to face. What does the NHS long-term plan say? 30% of people should be remote and video consultation. That's what the outpatient transformation program was set upon. And you know, when I stood up on stages before the pandemic and used to talk about it, people would laugh at me saying the NHS will never do it. It took a pandemic, but overnight we kind of went to that. But now we're coming through that, and it's going into just, we're getting used to living with that kind of thing now. We're starting to drift back to some of our old ways and old practices. But what we got through the door was the board at Mid and South Essex. It took us nearly 2 years, I think, to get it through, eventually approved over £1 million in our business case to help us work in partnership with eConsult to build what I think is the most advanced virtual outpatient system anywhere in the world. There isn't one that does everything that I can see. I've been to Kaiser, I've looked at the big, the Cleveland Clinic and the big groups in the United States. No one's got something that covers everything. They've got something that does a salami slice. Maybe some of them have got half a dozen salami slices. We've got the whole thing. So big ambition, and how could we do it? And you know, I said to eConsult, you'll have to do a lot for this. You'll have to raise money. You haven't got enough. I can't get you enough from the NHS. And I also said to them, I want the NHS to own some of this. I'm not sure how happy they were with that. So Mid and South Essex actually own a small stake in the outpatient platform. And to me, that showed the ethos of eConsult and their approach, that they wanted to do this in partnership with the NHS, because our clinicians at Mid and South Essex are helping design those excellent care pathways, you know, those questionnaires and things I was telling you about sending out to patients. Now, our ambitions for this are really bold. So once you've been through the pathway, you either can be discharged to PIFU, you're put on an inpatient waiting list, or you're discharged because you're cured back to your GP. Those are the three way out of the system when it's done. But the most beautiful thing is the GP and everyone in primary care, the patient and their carers, the secondary care clinicians, the management, the commissioners, NHS England can see the care pathway live the whole time, all of the time. No, look, when's my appointment? When's this? When's that? None of that coming through. Wow, a truly revolutionary system. Now, what's really big, and believe you me, I'm working on a piece of work at NHS England now on how we get this over the line. I haven't got the buy-in yet, but lots of people, we pitched it to, Chris came along with me and we pitched it to Steve Powers, his medical advisory group, a couple of weeks ago. I had 9 entrepreneurs pitching that day, and Chris came along and we spoke about the eConsult platform and what we were doing. And I stood up at the end and I said, this could be the thing that helps us address our workforce crisis. Because if you have a virtual clinician doing your triage on the system, and we will be bringing AI into it later, but not at this moment, that clinician doesn't have to be in Essex. It doesn't have to be in England. Could it be a clinician from anywhere across the world triaging that information, coming in and sorting it, so that our clinicians in the NHS are released to see the face-to-face appointment, providing everyone is managed to a standardized pathway? And I could go on and tell you more details of that, but I want to give others a chance to talk. So we've been at this for over 3 years now. eConsult have come on the journey with us. We've come an enormous way. I think it is the most advanced digital virtual outpatients platform in existence. I think if we get this right and we get it up and running, not only will it be world leading, but it could be a model that's rolled out globally for providing healthcare right across our planet, with this digital triage and plugging into tests, information, and then curation of stuff. I'm super excited by it. My colleagues at NHS England are also excited by it, but they go, Tony, we're going to wait and see what happens. Well, do you know, I had at Confed Expo, I had a meeting with Jackie Rock, our Chief Commercial Officer at NHS England. I told her all about this, and she said, I want a briefing paper on this. Why don't I know about it? What's going on? This sounds amazing. It's exactly the sort of thing we should be supporting. And she's not signing any checks, let me be clear. It would be nice, but the willing and the intent to support bold ideas coming forward. And that's what we're doing. Look, at that point, I've overspoken. I'm sorry. I'm going to shut it. I just get too excited. I could talk for long, but we want to hear from others. That's it. Back to you, Tim.
Thank you, Tony. It's so exciting, and it's great to hear how this came about. and the fact that it's been developed with you. It's not an IT company coming up with a solution and then trying to flog it to you. It's been really co-developed, and we look forward to hearing more about that. So to tell us about this salami, we'll now move over to Erica White. So Erica, can you fill us in from the MSc perspective about, what is this? What are we talking about? What is this big transformational project?
Sure. Good morning, everybody. So you'll all be aware that the NHS long-term plan set out a vision around empowering people to become partners in managing their health and care through the use of digital tools. And to support that, as Tony mentioned, approximately 2 to 3 years ago, we embarked on an ambitious program of work to revolutionise the way in which we manage our outpatient services across Mid and South Essex. And in order to future-proof, we knew we needed to focus on reducing variation and driving digital innovation. And as such, we decided to adopt a digital by default approach. Our goal is to take the latest advances in technology and to implement that alongside new ways of working. And as Tony mentioned, we expect our virtual outpatient approach to transform the interface between primary and secondary care, and will in time hopefully manage the whole patient journey from secondary care referral to completion of secondary care episode, or through ongoing management of long-term conditions. So to realise our ambition, we've opted to deliver our solution via a shared technology framework, working in partnership with industry leaders we've identified to create, develop, iterate and integrate relevant technology. There are a number of facets to the new outpatient approach, and today we're here to specifically discuss our innovative solution that we have been developing in partnership with eConsult. So it consists of 2 key tools, one being a specialist digital triage tool, and the second being a smart workflow tool for our clinicians. And that will be integrated with the NHS National Electronic Referral System, or ERS. So as you know, or hopefully know, eConsult are the UK's leading digital triage provider and currently have offerings in primary care and emergency departments. And when we started this journey a couple of years ago, as Tony mentioned, we felt that the eConsult primary care triage approach could be adapted to support outpatients. And luckily they agreed, and we entered into a partnership to deliver the UK's first blueprint for outpatient digital triage. The platform we've been developing will facilitate an end-to-end digital patient management system, which will empower our clinical teams to ask referred patients a specialist list of questions, triaging them at the outpatient referral stage and at all stages of the patient journey. And this will help us to reduce the waiting list backlog, join up care and improve patient experience. And essentially the approach has been to co-create intelligent branching question sets with our clinicians at pathway level. This digital first approach will enhance the patient experience by enabling them to take more control over their appointments, because the platform will allow the patient to share information ahead of a visit, enabling our clinical teams to identify the need for pre-consultation diagnostics, appointments with other relevant specialists before attending a clinic, or the need to bring more specialists into the room and take a multidisciplinary team approach. So hopefully this will eliminate the need to spend precious consultation time gathering the patient's medical history and symptom presentation. Instead, the information already presented can be verified as required. We expect the total number of visits that a patient will need to make to the hospital to reduce. Patients managing long-term conditions will be further supported by the eConsult solution, as we will use intelligent branching question sets to remotely monitor and triage patients who are being managed on a patient-initiated follow-up pathway. And that will enable our clinical teams to proactively identify those patients who may need further clinical input in a timely manner, providing a safety net mechanism for our patients on those pathways. Lastly, I would just say that as an ICS, we are aligned in our ambition to have a single digital front door for our patients, and as such, we will be utilising the NHS app via integrations to support access to the eConsult solution, as well as our digital patient interface. And that will simplify the interactions that our patients have to undertake in order to access health and care services across Mid and South Essex. So I'm now going to hand over to my colleague Chris, who will talk you through the solution in more detail.
Great, thank you very much, Erica, and nice to meet you all. So I'm Chris. I'm an NHS anaesthetist by training, and Tony's mentioned already a little bit about my route into the NHS England programme, and I'm now Chief Innovation Officer at eConsult, looking after outpatients specifically. So I'll just start with a bit of background and detail around eConsult and what we've done historically and where this came from. So leading digital triage provider across the country, We're in about 45% of GP practices, so several thousand, over 3,000 practices, covering just under 29 million patients. And we do, as Tony mentioned, more than 1 million online consultations every single month across the country. So a lot of kind of tried and tested scale of taking digital out into the clinical world. I'll show you in a moment what that looks like and dig into a bit of more detail about the product. But in essence, this is about, I think some of the power lies in the clinical safety of the question set. So it's not a simple questionnaire that we put in front of patients. It was designed right from the beginning by clinicians to be a dynamic question set and history take that can identify where patients aren't appropriate for that and direct them to more appropriate urgent care settings. And 2.5, 3 years ago, the thinking evolved beyond primary care, to, as Tony described, to other settings in secondary care, urgent and emergency care, but also outpatients. And that's when we started this project and started to think about how we can add value in a secondary care setting and run it through the same scaled up NHS approved infrastructure and all the information security and everything that's already there, and the clinical governance process that we have for creating content. On the right hand side, these were the kind of the 3 biggest areas of benefit that were identified early on. Can we use a clinical history take in a specialist setting to identify and remove unnecessary or inappropriate appointments? And that might be at the point of referral, supplementing the information that's come from the GP, asking specialist questions the way that they want them asked, and adding more information to better enable better triage of referral at that point. It might be much later in the timeline, so it might be pre-appointment, which, as you know, can be many months later. Something may have changed and we might need an update to better identify which are still necessary appointments, and taking a clinical history at that point. Or the third one within number 1 there on the screen is PIFU. And after discharge to PIFU, which has been mentioned, and it was second in the poll, can we enhance that current standard operating procedure of giving the patient a phone number, call back within 6 months or 12 months if you've got symptom X, Y, or Z? Actually, it might be that they forget some components of that 12 months later. Can we take a specialist history designed for a PIFU pathway at that point and better identify who we fill those appointments up with, and so that the right patient's in the right place? That's all in number 1. Number 2 is actually optimizing the clinics themselves, so where patients are still appropriate. We've got some evidence that I'll talk to in a moment about reduction of DNAs, but also in gathering that history up front. We did lots of this in primary care, but there are also lots of examples with consultants and clinical nurse specialists that we've spoken to at Mid and South Essex, where there's an element of some of their history take that's going to be predictable. It might be a scoring set that they want to ask of questions. We can get those answered in the patient's own time. And the third and final bit, which Tony alluded to at the end, networked working. It's in some of the Get It Right First Time reports for some specialties. We do lots across primary care already. Getting the more remote consultation that you have, and this was top of the poll today, the more that you can enable this across different sites across a trust and even across different trusts. And on the left of this screen on the slide, you can see what that looks like for a patient. So this is similar to what's out there at scale, and we've done 29 million of, which is a structured single question per page clinical history from the patient. The difference from primary care being that on the left there, the patient starts with receiving a text message, and that comes at whatever point is appropriate for adding the most value to that journey from the specialist perspective. But they still go down, they answer questions. It's a structured history because there's a restricted number of answers they can give, multiple choice. And that's deliberate because when the content is designed, we're trying to enhance the safety of it as much as we can, keep to a minimum the number of open text boxes that are in there, because you can introduce clinical risk when you do that. Just to break down again a little bit more on that value proposition, this is a traditional patient flow. So the patient gets referred to a specialist by a GP, joins a waiting list, and at some point later has a repeat history taken by a specialist. Now, hopefully lots of patients are in that top green box of safe, appropriate outcome, but inevitably in some specialties, there are some patients who it would have been great to have got investigation X, Y, or Z in place and having happened prior to the appointment. and it may not have happened. And so having the history up front can help to identify those patients in those specialties where that's appropriate. Equally, sometime later, and particularly in some specialties, some people may have got better. Their acne may have gone away in dermatology a year and a half later, but they still come in. Or they didn't come in, but they didn't manage to cancel, didn't have an easy mechanism to cancel. Or they may have got worse and actually they have some other symptom that they didn't want to go near a busy A&E department. And all of those routes are relatively poor journeys for the patient and poor journeys for the clinic. So the concept was always, can we take the right history up front at different points in the timeline, depending on the model, and actually also identify whether this is relevant for face-to-face or telephone or video, which might help towards that goal of increasing remote consultations. Some of the work that preceded Mid and South Essex, so across a 12-month piece of work in the University Hospital of Wales, this was a dermatology clinic, an acne clinic, and the graph on the left is a projected waiting list completion time. So the blue line out to 2043 is before eConsult came along. The red line in the middle is what happened over 12 months with a reduction in the waiting list projection by more than 10 years. And that was straight away following pre-appointment questionnaires, even though the clinicians were taking their own time, digging into their appointment time, sending these out. Now, so it's just showed the efficiency that's been brought in there. The yellow line is a projection as to what happens next now they've got dedicated administration towards sending those out. And the other interesting thing here was the DNA rate came right down. It was very high in an acne clinic, 40%. It came down to nearly zero. And the consultant looking after this project, as you can see in the quote there, said that she's not aware of any other quality improvement implementation to date in the health board that yields such marked efficiency savings. So on to Mid and South Essex and the big piece of work that we've talked about and alluded to already across 40 different specialties. We're taking, a very collaborative approach, as Tony and Erica have both said. We're very lucky to have lots of specialists inputting into the pathways, taking that into our clinical governance process that we have already. But I'm conscious that we want to take a balance between one size fits all versus bespoke for every single trust and every single specialist area. Somewhere in the middle, there is a variation of pathways and a collaborative approach. So if you may have particular specialty areas that are a problem, we may have pathways already built that could address that problem, or we may have variations of that we could co-create with you. To give you an idea of where we are today, so hepatology went live a couple of weeks ago and have started, and they're doing a triage of referral with the pathway they've built for that. We've got, just in the process of going live this week, we've got trauma and orthopedics, we've got pain on chronic pain pathway, and part of urology on a lower urinary tract symptoms pathway. And we've got a number of other specialties that are all trained up, ready to go, and have created content that's already just about to go live imminently. Some of the higher volume ones, so cardiology, urology, the rest of urology, gastroenterology, the other ones on the screen there on the slide. So clearly this isn't the whole project. This is 10 roughly specialties, and we've got another 30 in content creation at the moment. But across the board, the great thing is that each and every specialty has taken a look at this and said, brilliant, we know this pathway would be the first port of call for this. We can add value straight away because of the breadth of what we're doing. What I'd love to do right now is to ping up another poll for you just to see what specialties, or which specialty in particular would benefit the most from this type of solution from what you've heard so far. So if you could pick one, that would be great. And it will help us to just inform some of the order that happens next and just get an idea of where the biggest problems are for your focus areas that you've already identified in the first poll. I'll just give you a moment to complete that. Dermatology is near the top. I'll come and revisit that later. To dive into a little bit more product detail here. So on the left, you've seen the patient side and the structured history that they give on a mobile device or a computer. On the right, you can see what that report looks like coming into the clinical service area in outpatients. So today that drops into an NHS mail inbox. So a given service area will say, we'll set up this mailbox for this service within this specialty, and that's where those reports come in. And as you can see, and this is what we do at scale across primary care as well, with different content, every question and every answer is on there with specific flags that come up. So any content that the specialists co-creating this with us have said, that needs close attention. If that combination of answers comes through, we flag those specifically on those reports. And there's a lot of clinical governance and different types of flags that go into that content creation process. But the really exciting bit is what comes next. So this is about not giving somebody and clinicians and administrators somewhere else to log into, but pulling all the bits of the disparate systems together. And this is a principle that runs across everything we do across primary care as well. What we've built in collaboration with Mid and South Essex and across primary care is a smart inbox, which you can see on the screen. So this is something that floats on top of clinical systems to help us to add value to people, to users, to better manage their digital queue. Historically, we sent things directly into clinical systems, and that's because clinicians didn't want their workflows interrupted, which is completely understandable. But that limited our ability to add more value with fewer clicks and different operating models that you've got across different specialty teams. This sits on top of clinical systems, writes back to them, talks to them behind the scenes, doesn't obstruct your view of them where you need your workflow in your clinical system, but does give you things like sorting, filtering, tagging, assigning to different teams within your area, and very soon bringing in ERS referrals as well. This is all about reducing the number of things that clinicians have to log into and administrators have to log into. And the exciting thing, as I mentioned, is that this is in place across primary and secondary care, so it can start to bridge the gap between those areas. I just wanted to touch on some nice positive feedback we've had already, even though we're right at the beginning of this in terms of specialties live. This is one of the senior physiotherapists in trauma and orthopedics who said how super impressed he was by how easy it was sending questions to patients, how easy it was for them to respond. He gets his scoring systems calculated automatically. Just that alone saves him minutes for every single referral. And he said it really adds up. It seems minor, but he's so pleased with the difference it makes. And hepatology, who've just started as well, they're expecting to see just an overall improvement in the patient's initial assessment. They're keen on getting the right investigations ahead of time, as I mentioned, getting things arranged in the right order, but also really crucially allowing the patient's thinking time about the symptoms they've got, but crucially in hepatology, a bit more about the family history. Can I talk to my relatives in my own time, get the right family history rather than being in the room with the clinician and not having all that information to hand. And ultimately their aim is to reduce waiting times, improve the quality of that consultation, and ultimately review the time taken during it, because they think there are elements that can be reduced, as I mentioned earlier. So I just wanted to close on trying to sum up and articulate the opportunity here. I think we've got a tech platform that sits across primary and secondary care. You can imagine an outpatient setting where every patient seen was appropriate to be there, had the right modality identified already. Back to the results of the poll, getting somebody that you know is actually going to be relevant for video or telephone. Our system allows you to go upgrade and downgrade between those two. So if you will never know potentially if the patient might have trouble getting into video. With a single click, you can downgrade to a phone call and not worry about their connectivity or their tech skills. You can imagine a scenario where every patient's had the relevant recent history taken from them, asked in the way that the specialist would have asked those questions. They've invested their own time in doing that, so they're more incentivized and invested in attending the appointment with you, as we've shown in dermatology. They're confident from their perspective that the GP, they've got a digital accessible route into the GP. They've got a seamless transition to the specialty scenario and a referral. They're confident that those teams are on the same team, drawing on each other's expertise, that they're giving a real-time update to their situation rather than plugging in siloed information gaps between the two. And they're confident what they're being asked to do, if it is to drive into the hospital or to receive a phone call, that they'll get the right things in place in the right order. This is ultimately about getting the right patient to the right place at the right time. And as Tony mentioned earlier, the different slices of the salami, there are kind of point solutions out there across different specialties, and there are patient portals like Patients Know Best. And we think all of that is part of the solution as a whole. And I really like the fact that our approach is that we glue all of those together. We're the triage part, because that's what we do and we have at scale across the NHS, but we're very open to bolting on all the other components that are needed as part of a joined up solution that takes you all the way through and does a better job for health and social care. So I'm going to wrap up there and hand back to Tim, and thanks for listening.
Thanks, Chris. Very clear description. Thank you very much. So it's exciting to hear about the two aspects of this new program, with the digital triage and then the management, the workflow tool with the smart inbox tool. But I guess we've all seen how technology doesn't always deliver the anticipated benefits, because it's all really around the implementation. So perhaps I can ask Tony, as a clinician, what's Mid and South Essex doing to make this system work in real life? How are the clinics being restructured, reorganized to make use of this?
Sure. With any piece of digital transformation that you do, if you want to make it work, I think top-down mandation is not my practice and the way forward of doing this. And I think although people in NHS England, I recall I went before the Health Select Committee once, and Baroness Neville Jones, who used to run MI5, was a real top-down, as you couldn't get what I want to do, which is win hearts and minds. She was top-down. And what we've done is we've brought our clinicians with us. We've gone to them. We've co-created with them. We've said, look, we've learned an enormous amount from the pandemic, and that did benefit us, because we were getting the approval for this before the pandemic. The pandemic actually slowed down the approval process a bit while we focused on the immediate operational need. But actually, as we were getting through it, we looked at it and said, we've got to do this more and more. And our clinicians have actually welcomed it with open arms, particularly in some pressed specialties. And it's about taking that time. So we've appointed at Mid and South Essex an outpatient lead and given them time in their job plans for every single specialty. That's a commitment that my execs at the trust put forward. Doesn't necessarily mean new money, because within clinicians' job plans, there are various activities and things we can work for, but sometimes it has meant that, and we've allocated that where we've needed it. But we've worked with clinicians. We've said, what are the core priorities for you? What are the real pain points that we could resolve? I recall, and I go on calls with them every week or so to meet different clinicians. To do that, we did it recently with our general surgeons, and in particular looking at breast surgery. And one of the things they wanted to prioritize was the family history collection for breast cancer. Really important thing, can be done completely digitally, often by engaged younger people, and you can map your family process. But these are taking up a face-to-face outpatient appointment, which isn't necessary in breast services. And they started to do it in the pandemic. They learnt a lot from that. And what we've been able to do, or we're planning to, is port that over into the eConsult system, keeping that way of working that our breast surgeons found of great benefit. There are a whole range of other things, for example, colonoscopy follow-up in general surgery, and the recall of patients for that, and knowing who had what polyps were, all managed on a clear pathway that can be seen by all. So that's another area we're going to be working on. So our approach has been very much to work with the willing, to go along to them and say, what are your key problems? How can we work with you first? Where's the biggest pressure coming in the system? What things out there are excellent that you've seen that you might already be working with? And as Chris said, we can just plug them in. eConsult is a bit like an API where we plug excellent. We don't have to reinvent every excellent care pathway. We're working with a number of different people who've developed amazing pathways that have been validated according to best practice standards, whether that's NICE or international organizations that have taken that forward. And when you take that approach and you first of all have the courtesy to professionally engage with clinicians as real people rather than on an email, you listen to them and their problems and what it is. You have it clinically led within an organization, and then you back it up with a team not just within the trust, and that's where Erica and her team has come in to actually deliver on the management, but from within the tech provider and company as well, as we've had with eConsult. And so the consultant, because you can imagine where everyone's weary and they're going, oh, not another innovation might be the approach, not the experience we've had. They've turned around and said, wow, this is going to take some real problems away from us and help us to deliver high quality patient care. And so I think that approach of exactly how we should be doing it. This is how you would think all things would go forward. The sadness is in the NHS and in other systems as well, I've seen it, it doesn't go forward like that. So I think we've got an exemplar of clinical engagement, of executive and management buy-in and leadership of the programme, and a really great partnership with eConsult. They've risked a great deal on this for sure. Why? Because it's the right thing to do. It's a bold thing to do. And clinicians get that. There's no new technology here. We haven't had to have a Nobel Prize winning discovery to make this happen. We've just had to bring all the right partners together, including clinicians, also our patients. Patients have been involved with this from the start, looking at that and getting their feedback, getting their thoughts and advice on what we can do and how we can improve it too.
Great. Well, it's really good to hear that clinicians are embracing this so warmly. As you mentioned, thinking about the patient perspective, I guess we can all see, and probably we've all experienced from one way or another, the frustration of the traditional outpatient model. But what about the patients who are less digitally literate, the elderly, for example? I think Joanne asked about elderly patients. Is there a risk that this is going to cut some people out?
I'll jump on that one, Tim. So, and this does come up quite often, and rightly so, because it needs to be at the forefront of our minds. One of the things I think it's partly a byproduct of getting our solution out there so widely in primary care is that this has a lot of solution thinking behind it. How right from the beginning, the inception of it, how do we get the right human support in the NHS organisation that we're supporting to connect with the patients who want to get in but are diverted into digital? One of the things we have is called eLight. So it's essentially a way that a receptionist or an administrator can help. So if somebody's called in on a phone line, and this applies in Mid and South Essex on the referral support service, the RSS, team of people who can pick up the phone and start to complete one of these for the patient over the phone. And that means that they don't lose out from the consistency that the specialist history kind of gains for them, but they also don't lose out from the inability to click on the link or not having a mobile phone. That's one of the things, and there's a whole range of other accessibility components for specific groups of patients, and we have a maximum reading age that all the content goes through. Lots of processes to make sure this is as accessible as possible. So it's really important.
Tony.
Tim, yeah, sorry, I'm with my real hand rather than a digital one. I haven't found that button yet. Do you know, we do that in our patients now. I give patients in urology clinic an IPSS, International Prostate Symptoms Score Sheet, and some of the patients, particularly the elderly patients, sit there and they say to the nurse, "I'm so sorry, I don't understand it." And it's pen and a nurse has to sit there with them, read them the questions, and which one do you think? And then they present the score to me when they come in. We're not just digitalizing this, and if you don't get it, you don't get it. You can see what Chris has said there about the ability to have a telephone call to talk someone through that, to help them do that. This could even happen in primary care with navigation of and helping taking that forward. The system is still in design in what we're doing, but believe you me, health inequalities and ensuring that we don't increase those, and making sure we increase digital inclusion as we go forward is at the heart of what we're designing and doing. But at the moment, we've got a system where if you want to be digitally enabled, you're excluded, because we don't offer that. You have to come up face to face. You have to queue at the car park. You have to pay whatever it is you have to pay. You have to wait for a long time sitting in that chair next to everyone else and be grateful, is kind of the feedback I get from patients. I've heard that many times at Southend. And for my kidney stone follow-up patients who've had a scan as outpatients before they see me, and they come in and they're fine, but they're very worried they might have one of the most painful experiences of their life again. I do it on the telephone at the moment. They love it. And that's stayed since the pandemic. I'd say 98% of my stone clinics now are on, what, examining them? How do I find a kidney stone examining you? I don't. I have to have a scan. So there are some specialties which will go almost exclusively, and bits of those specialties, to this kind of thing. And the patients love it. I haven't had to queue up at the car park. I haven't had to sit there. I can get on with my life, and I know you're going to call me at a certain point. And particularly where we are in Mid and South Essex, lots of commuters in and out of the city, they really value the opportunity not to take a day off work to sit there and do these things. So it is at the heart of what we do, and Chris has indicated that around digital inclusion, but also we have had a kind of an everyone's analog by default approach pretty much in the past, and we need to rebalance that. The analog's never going to be switched off. You're always going to be able to come for that face-to-face appointment. But for those who need it most, they'll be able to access it in a much more timely way, because those who want the digital option are going to be able to take that up and embrace it.
That's great. Sadly, we're running out of time, but I think there's just time for one last burning question that I think everyone's asking is, when's this going to be available for other trusts and ICSs? Is this something that's going to be available soon?
So we've got the pathways that we've built already, and pathways that can be tweaked as well. And in some cases, it might be brand new pathways that you have a need for. Me and my team would love to connect with trusts who are interested, talk you through it, give you a demo, and ultimately, as Tony said, take that kind of clinician and whole system, all stakeholder approach, talk you through how we can do it. So the short answer is now.
Great. So people should just contact you.
Everyone will get emails after this, I think, following the webinar. Some from my email, so they can reply direct to that, and we can get that sorted. Yeah.
Fantastic. Thanks, Chris. Well, it's sad we've run out of time because there are other questions, but rest assured, if you've asked a question and it hasn't been answered, we will get back to you by in the emails. And this is, as I mentioned, this is the first in 3 webinars. And if you can hear a dog in the background, I'm afraid my dog's having a dream at the moment, barking. The second webinar is going to take place in September, when we're going to hear from clinicians who are actually using the system. So we'll be sending out the date for that webinar. So I do hope you can join. And lastly, the recording will be sent out. Do share this with your colleagues, and we'd like to get as many people aware of this as possible. Such an exciting initiative. So with that, thank you very much, Tony. Thank you, Erica, and thanks, Chris. And thanks everyone for joining today. I look forward to the next instalment in a few weeks' time.